Well, next, I want to introduce our panel. Tuberculosis is the world's leading infectious disease killer. Our panel today will discuss how ECHO programs are working alongside ministries of health and other local international health leaders to eliminate the global burden of TB. Bruce Strumminger, our Senior Associate Director at the ECHO Institute, will lead this discussion, and his colleagues' names will appear here on the screen. Bruce, panel, please come on up. Thank you.
Thanks, everyone, for joining this morning. Of course, we saved the best for last. So very much looking forward to this panel discussion. You know, really, in a way, it was the challenge of helping eliminate TB that first brought me to an interest in ECHO. And when I served as the CDC country director in Vietnam, 2009 to 2012, I was also the Stop TB co-chair. And addressing MDR-TB, multi-drug resistant TB, was one of the biggest challenges in Vietnam. When I read about ECHO in 2011 in the New England Journal article, the first disease that came to my mind needing this was TB. So it's super exciting to have this panel discussion. So we've got 4 distinguished panelists, 1 from Vietnam, 1 from Tanzania, and 2 from India, who are going to share very different perspectives on adapting the ECHO model to address the TB burden in their countries. So I'm going to ask each panelist to just spend 3 minutes giving us a brief overview of the TB burden in your country and of how ECHO, why ECHO was started from your different perspectives to address a particular problem as you helped achieve TB elimination. So I want to start with Lan, because Vietnam was the first country in the world to adapt ECHO to address TB. Lan?
Thank you, Bruce. First of all, I feel extremely humbled to be with my fellow panelists who have been involved in the world of TB for many, many more years than me. And I would like to just say thank you for giving me the chance to be here among you all. So my name is Lan Nguyen, and I've been an ECHO consultant for the past 5 years for Vietnam. And I knew about the ECHO model back in 2014 when I was in grad school. And I needed a project for the summer, which was when I came to Albuquerque to work with Bruce and then know the amazing team at the ECHO Institute, Sanjeev and everybody. I learned about the model, brought it back to Vietnam that very summer, 9 years ago. 2014 was the years when Vietnam still faced with an extremely high burden of multi-drug resistant TB. So just a brief context, we rank 11th both in the number of TB cases in the world and also the number of multi-drug resistant TB patients in the world. Back in 2014, the only treatment for MDR-TB in Vietnam included injectables, which was really painful and complex to manage. And this was when the NTP didn't have a very good model to bring the treatment down to the provincial level. Everything needed to happen in person. So when ECHO, the Project ECHO, was introduced to the NTP, the leadership back then saw it immediately as an opportunity to bring MDR-TB treatment down to the provincial level, to train provincial lung hospital physicians on how to manage MDR-TB patients. And right at the beginning, they issued an official dispatch to roll out the Project ECHO into all 63 provinces in Vietnam with regular patient consultation using the ECHO model to tackle the MDR-TB burden. And since then, it has been 9 years. Project ECHO has been utilized in Vietnam not only for MDR-TB, but also for COPD, lung cancer, asthma, and a number of specialties within the purview of the National Lung Hospital.
Thank you, Lon. I now want to turn to Ravindra, who is the director of the National Institute of TB and Respiratory Disease in New Delhi, which was the partner in India that started the first TB ECHO program in India, to tell us a bit about that journey.
Thanks, Bruce. See, first of all, to put things into context, India is having the highest burden of tuberculosis in the world, with almost 2.5 million cases per year, even the cases reported last year or so. And so, but in it, the heartening feature is that our government and our state apparatus is actually supporting that and is very keen to eliminate TB. In fact, our Prime Minister, when we said in the Sustainable Development Goal, we will end TB by 2030, he advanced the date to 2025 and has pushed a lot of emphasis on all of the health workers who are working for it. So National Institute of TB and Respiratory Diseases, we started ECHO clinics in 2016. Primarily, we were targeting an audience of TB workers across the country. And initially, in the first years, only 600 people were attending the clinics. But over a period of time, now we are having a situation in which 10,000 people are attending the clinic annually. And we are running 4 clinics, because one clinic is a difficult to treat TB clinic, which is most enthusiastically attended. And as my colleague mentioned in the morning, this clinic is also attended by the senior government ministry officials, and almost on a regular basis. Then there's a clinic of HIV TB, and that is run twice a month. Then there's a clinic of myself being a thoracic surgeon, thoracic surgery clinic, which is also run once a month, in which, because thoracic surgery being a niche area, very few people are available in the country, but we are able to discuss our problems. For instance, I remember a story in which a patient who had undergone a TB treatment for pleural effusion, and there was an opacity which was still persisting. And the surgeons were thinking of starting the ATT again. But somebody in the panel said, no, this looks like something else. Please do the CT scan analysis and surgery. And it came out to a dermoid cyst. So this happens. Once we interact with each other, newer things emerge. Then we run a very important clinic of nurses, in which we are training nurses in situations like, number one, they get some sensitization about the programmatic management of TB. Then the issues related to psychological support and counseling. I think 3 areas in which patients require a lot of counseling is, number one, they have to take the treatment completely. Number 2, if there are adverse events, adverse reactions or side effects, how they have to be addressed, and how they have to be supported psychologically in terms of that they do not get demoralized during the treatment. So these are the 3 areas in which nurses can do a lot of help, and we are concentrating on these areas. And when the COVID pandemic came and the country enthusiastically embraced the Zoom model, in fact, our All India Institute of Medical Sciences ran every week or various aspects of managing COVID for all doctors and nurses and healthcare workers, even general public, they opened it. And they were very enthusiastically attended. So that's why the interest has increased. But we feel that nurses are very important in the point of care of the patient. If the care has to reach absolutely the last person, nurses are very significant. And we are getting a very good response. We are continuing to evolve and learn from the model. Okay, thank you.
Thank you, Ravindra. As you pointed out, your first program, which started, I think, in 2017, started with multi-drug resistant TB, just like in Vietnam, but you've expanded over the years to complex TB, TB HIV, surgery, et cetera. It's diversified. Also, the success of your program really inspired the government, and we'll come back to this, the government of India in donors to support the scale up to now over 70 different TB ECHO programs all across India. One of those programs, Anil has been involved with, who is based in Chennai, that works with medical colleges specifically. So Anil, please tell us about that.
Thank you very much, Bruce, and it's a great opportunity to be here and learn from the wonderful stories that we've heard about ECHO. May I just chip in and say that being part of a medical college or a university is a slightly different responsibility that we share as teachers, teaching what the curriculum requires, doing what a patient requires when coming to the hospital, and slightly different work when you go out to make a difference in the lives of individuals affected by the disease in question. Hearing to so many personal stories, may I very quickly share, I haven't done this in any other public platform, but TB came home to me in a tragic way when I unfortunately lost both my parents, my mother and father, because of TB or its complications. We read, we think, and we treat, but then it becomes more meaningful when you try to do this in others. There are over 560 medical colleges in India, a huge part. They are more concentrated in the southern part of India. And as part of the national program for TB elimination, the program managers felt medical colleges and those working in medical colleges could collaborate and work together in this program. Perhaps one of the few examples in the region when we had perhaps about 15 years back when we met together and formed something called a national task force, a zonal task force, and a state task force. This is only to get all the medical colleges working together on a common platform to find out how best we can diagnose patients early, put them on treatment at the early date, and also monitor their outcomes and share. Medical college, in a way, provide treatment for about less than 10% of total number of TB patients who are treated. But to start with, when we started, data showed that we were treating just about 10% or less than that. That's increased in some states where medical colleges continue to provide an increased level of involvement in the national TB program. Well, how does ECHO help? ECHO has provided us that platform to bridge the gap between the necessity of traveling from one place to other and the platform that has been made available very, very cost-effectively to us helps us continue with our review meetings almost every quarter, 4 times a year. May I also share that this ECHO platform has given medical colleges in India and the state program and the national program the opportunity to conduct regular review meetings with many of the metrics that have already been shared to find out what was said, what has been the difference. So very briefly, I cannot really think of a better opportunity and a collaborative experience that we've had with ECHO in reaching out to the people affected by TB with regard to diagnosis, treatment, and now they're thinking of how to provide treatment and extension of care for complications. Thank you, ECHO.
Thank you, and you know, the scale of India is mind-boggling. And as you're pointing out, when you say only 10% of the TB cases in India are treated through the medical college system, there are 2.5 million TB cases treated a year in India, which means the medical colleges treat 250,000. To put that in perspective for everyone, Vietnam has 100,000 active TB cases a year in the entire country. So your medical college system is actually treating 2.5 times the number of TB cases that all of Vietnam, a country of 100 million people, is treating. So it's important to understand the scale that's going on there. So now we're going to shift to Africa and Zambia in particular. Emmanuel, can you tell us about how the TB portion of the ECHO, how Zambia has used the ECHO program to address TB in Zambia? It's taken a different approach. These other programs were vertical TB ECHO programs. That was the only topic of those programs, where in Zambia, TB has been integrated into the HIV ECHO, as I understand it.
Yeah, thank you very much, Bruce, for the opportunity. Zambia has actually a story to tell about how ECHO has been implemented in regard to TB. So this is a Southern Africa country. Zambia is actually situated in Southern Africa region with a population of roughly 20 million and 1,300 million people on HRT. Understanding the factor of HIV-TB co-infection, we were actually having a high number of advanced HIV cases and mortality due to that co-infection, and also late diagnosis of those who are mono-infected to TB. So that's where we are coming from. So we really had challenges before we started the project ECHO. Situations where the index of suspicion of TB cases among clinicians was actually very low. The negative perception of TPT management among healthcare workers. So we had scenarios where TB management was centralized to level 1 hospitals. For MDR, it was actually divided into 3 regions. So if you have a client who is suffering now of MDR, they have to move some good number of kilometers to reach the regional hub. So ECHO, when ECHO came in, that was in 2018, it came in as a beacon of hope, actually a testimony, a testament of innovation. So we actually, as Zambia, we look at that, and we saw to it that it was important to actually do the intensified case finding, and that was through capacity building, and ECHO was used as a platform. So that worked very well. So as we are talking now, we are able to screen TB at the health post level. So what actually moved to the next level is the sample, but a client or the facilities are now treatment centers with, of course, a diagnostic center within the catchment area. Then secondly, we have been able to decentralize the MDR-TB from the regional to have MDR-TB treatment at level 1 hospitals, so which is a plus. So now what it has actually resulted into a better patient outcome, because healthcare workers in these health posts, health centers, level 1 hospitals are able to screen TB, they are able to manage, and the outcome has been good. So the intensified case finding has actually improved, and we've gone to 60,000 as a yearly notification of TB. Then one other thing, we did the SAGE for TPT, that was in 2020. Because of the negative perception among healthcare workers, we had to run some ECHO activities. And when we started with the SAGE activity, it actually went on well. As a result, we are having very few, the proportion, the HIV-TB co-infected are now lower than the mono-infection. So which has shown us to be a plus. Then ECHO has also helped us to actually link the clinical mentorship. You have the mentor who collect a case, a real case at granular level. And this case is actually taken to ECHO, where we have the subject matter expert, pediatrician, public health specialist, epidemiologist, where this case is discussed. And when the case is discussed, it is taken, the recommendations are taken as part of policy, and it's supposed to be implemented as such. So in few, this is what we've been able to do. And one thing which I would love also to mention, Bruce, is that we have in Zambia what we call every year we have 2 weeks, a week every 6 months, where we do a care worker screening week for TB. So before that event, we run an ECHO activity, then we have the activity being implemented. Then after that, we evaluate. So it has helped in awareness as well as capacity building. So that is what we've done as Zambia.
Thank you, Emmanuel. I want to bring us back to Vietnam, where the TB-ECHO journey began, and ask Lan if you can think back 9 years, because it was 9 years ago that you helped start that program. What were some of the challenges in getting it started? What were some of the enablers? What were things like Professor Nguyen being there, I think, was an enabler to make it possible? And how have things evolved over that 9-year journey? I also want you to point out, because we've talked a lot about sustainability in different sessions over the last couple days, my memory is that the TB-ECHO program in Vietnam has never had $1 of outside financial assistance from the beginning. It started as a government-funded program, and it has remained a purely Vietnamese government-funded program, as I recall. So please.
Yeah. So 9 years ago, this was the pre-COVID era. So Zoom was something that was completely new to Vietnam, and so was online consultation of patients. So when we first started, there was great concern about how the physicians and other healthcare workers would be able to engage in this entirely new platform, especially the older physicians who are not very used to technology. And then the second concern for us was, here you are, you have a board of subject matter experts who are all teachers and who are at the highest level of management in the NTP. So there was also a concern that people would not dare submit cases where they're treating MDR-TB patients for fear of being criticized or scolded by their teachers. So both of these concerns were very quickly resolved because of so I would say the biggest enabler was the overwhelming demand from the field, from the provincial level hospital, where a lot of MDR-TB patients first came. That was the first entry point of theirs, and there was no way to treat them. People did not know how to treat them. They merely referred patients to the central level. So that quickly resolved all of the hesitation with engaging with the online consultation platform. And so was the second problem. So it actually took some time for the subject matter expert team to follow the ECHO model in the sense that they sat back and listen and learn how to really facilitate the discussion without the urge to jump in and give advice right away. So it was for the NTP, I think, a learning curve, but also something that they greatly appreciated. And to the second question about sustainability, Bruce, you are right. This has remained something that the NTP has funded over the years, because they do have the mandate to train all of the 63 provinces, not only in terms of MDR-TB, but also other TB-related problems. So right now, the MDR-TB training program happens in 3 regions of the country, just because it's spread out. Vietnam is spread out vertically like this, geographically. So they have a northern consortium, a central region consortium, and also a southern consortium. And each of these runs a different ECHO program that address the issues related to TB in their regions. And they use their own funding for it.
And I think you were going to say that it's also diversified from TB to other
lung diseases. So a huge enabler from the start, Bruce, is really the strong commitment and the leadership of the then NTP director. And it has been the same for the past, very fortunately, for the past decade. Like the continued commitment of the NTP to end TB in Vietnam by 2035. That is the goal, because we're set back by COVID-19.
Thank you, Lan. And Ravindra, back to India, I wonder if you can share your thoughts. I know given that India is the country with the largest burden of any country of TB, and that your Prime Minister has set ambitious goals for TB elimination, can you reflect for us on your thoughts on TB elimination in India? How will India achieve this, and what will the role of ECHO play in that as you see it?
Oh, thanks, Bruce. See, the complexity of TB burden in India is the highest. Not only in terms of numbers, it's complexity in the forms of type of patients that we get. For instance, TB with diabetes, TB with HIV, TB in pregnant people, TB in children, and there are several, in addition to malnutrition and less nutrition that many people are suffering from, and that further predisposes them to develop TB, and they do not get well even on a successful treatment. So these are the challenges which Indian system is facing in tackling its ambitious goal of eliminating TB. You see, though the goal has been advanced, in 2017 we started in a serious manner to advance the goal to 2025 and working towards it. And many initiatives started at that time, which included that we will be doing a bidirectional screening of diabetes, bidirectional screening of HIV people. We will give some selected group of patients, we will give TB preventive therapy also. But all these efforts, you see, in 2018 and 19, we had 2% annual reduction in the incidence of TB, which was not going to eliminate TB by 2025 at any rate. And then came COVID. For 2 years, we had a serious setback to the program. But it was realized by 21-22, the program hurtled back to normalcy almost. And in 22, by mathematical modeling reasoning, we have achieved an 11% reduction in the incidence. So there is hope that this program is advancing. Very unlikely that we will be able to control the disease by 25, but we are progressing. The increasing thrust which has been given to the program and the newer initiatives like TPT being addressed, given in a serious manner all over the districts. Then, as Dr. Anil mentioned, medical colleges are also being involved in teaching people how to treat TB in a programmatic manner, and then involving all other people. For instance, we have a community to be involved in treating TB. Our Prime Minister started a scheme called Nikshay Mitra, in which we ask anybody who is reasonably affluent to contribute or adopt patients in the terms that he or she will support that patient throughout the treatment, in terms of a nutritional basket, information available, or if possible, skill development. Because many people suffering from TB develop, they lose their livelihood. And that's a very major concern for them. And we have to ensure that they continue to get that livelihood. So the TB program is now being addressed in a multi-pronged manner. Not only initially our goal was fixed to finding out sputum positive cases and treating them fully. But now we have advanced beyond that. We will be treating patient as a whole. Whatever are his psychological concerns, his social concerns, economic concerns, as well as address the whole community to be involved, that we are all part of the program to eliminate TB. In fact, there's a slogan called TB harega, desh jeetega. Means TB will be defeated and our country will win. That's the kind of energy which has to percolate down. Most of us, including those who are seriously working, do not think that 25 is a realistic target, but just because the target has been set, our efforts have accelerated, and there is a lot of hope that we can achieve those goals. And many learnings are being developed. We are learning a lot during this journey, and those lessons are being added to it. I think some newer initiatives and researches, for instance, this TB vaccine, which is, we are trying to start BCG vaccination of preschool children or in the adolescent groups again. And there are some other initiatives like maybe we can some new drugs, and the researches are also being done. As far as the ECHO model is concerned, our ECHO, the National ECHO for TB, that is attended not only by government officials, and me being the director of a national institute, but there are 2 other national institutes. One specializes in National Institute for Research in Tuberculosis, and one institute specializes in training. So they are also being involved. All of them attend this very seriously. And Government of India has come out with establishing Center of Excellence. For instance, they identified my institute as Center of Excellence for general TB care and thoracic surgery, one institute for palliative care, one institute for rehabilitative care, one institute for research, and then they also promised unlimited financial support for developing those areas at least. And in addition to the government support, a lot of support from corporates and NGO fundings also came. So we are able to at least scale up our efforts. So hope is there. Realistically, because we have been working for almost 20, 30 years, We know that 25 is a target which appears very difficult to achieve, but hope is there because we saw in 1995 when we started seriously addressing the problem in revised National Tuberculosis Program, and by 2015, we had 42% reduction in the mortality of TB. And now we are seeing that increasing in the incidence of decrease in TB. So the things are hopeful. That's what I say. Thank you.
Thank you, Ravindra. I want to keep us focused on the big picture here. Anil, I know you're also have a national role as the vice chairperson of the National Task Force for TB in India. So from that point of view, how do you see ECHO helping with the TB elimination goals? And also, how is ECHO being integrated into the health system? I know that ECHO was actually specifically put into the multi-drug resistant TB guidelines for India, but from how else is it being integrated into the health system?
Well, ECHO India, in a big way, has been very, very closely collaborating and supporting the National TB Elimination Program, right from the central, state, and to the district level. Just to share a short figure that I am aware about, data suggests that there are over 200 ECHO programs that are conducted every month. So you can think about the enormity, the preparations that need to be done, the populations that have to be done, leave out Saturdays and Sundays, 5 to 7 every single day, to do with TB diagnosis, to do with TB treatment outcomes, but more important, I think, reaching out to the peripheral health workers who are involved in providing treatment and the diagnosis to these patients. Medical colleges have come to play an important role in two ways. Number one, advocacy, because medical students who are to be the doctors of tomorrow learn that this is an important disease, and when they go out, they need to do something about it despite whatever specialty they may decide to take up as their career. So I believe medical colleges have an important role because medical teachers sometimes are also emulated by students or medical students as their role models. ECHO platform now is being used to train medical students through a very specific training module that the program has developed, and we are utilizing to the maximum in training medical students across. We've been able to set up in our own mechanism a target that every medical colleges in a particular state need to do this during a particular month and during a particular quarter. And through the, again, platform of ECHO, we are able to monitor it, supervise it, and also have data showing that there is improvement with regard to this particular indicator. We, as Dr. Ravindra mentioned about the impetus on research, we are glad that the Government of India has been providing a lot of support, financial support for operational research to find out what works when, how, and what are some of the challenges. Many of the operation research committees that operate now in India at the state level, zonal level, and national level are carried out through the ECHO platform. We're able to very, very efficiently review the proposals, get back with the feedback and suggestions for improvement, if any, and provide the much needed feedback to the investigators on the ground that what you need to do to say that. Same way, of course, the financial aid would follow, but getting that into a publication, the pre-publication data, again, gets shared to those sitting at the program level. This is what we found out, and this is what we need to do in order to improve our outcomes for TB treatment in this particular region. Really, Bruce, I can't think of any other platform that we can now work 2023 onwards other than just on to what ECHO has been providing to us for the TB program through this network in India.
Thank you, Anil. Before we turn back to Africa and Zambia, I want to remind our audience, or tell our audience, we've got about 11 minutes left, that we want to open the dialogue up to questions from you and comments from you. So after Emmanuel answers my next question, we're going to turn to the audience. So please start thinking of questions and comments you'll want to share with us. So Emmanuel, as you're thinking forward toward the next couple of years in TB elimination in Zambia, how are you seeing evolving the use of the ECHO platform in Zambia to help you with TB elimination in Zambia?
Thank you very much, Bruce. Of course, ECHO as it stands for the Ministry of Health, it is now a matter of policy to have ECHO incorporated in the routine work of healthcare workers. So as it stands for now, we are at the stage where we have very good coordination at national level, provincial and district level. That is part of governance, and it is actually robust. We are also taking advantage of the leadership, as I've mentioned, as part of our opportunity to run further with ECHO. But we also have some hiccups here and there, like the issue of burnout from healthcare workers. We have issues where there is not that consistency in attendance of the ECHO session. But the way we've worked about those gaps is by ensuring that, one, we have these topics, the curriculum itself is designed in the sense that it markets itself. So we've moved from the number of cases delivered to how is the network involved in what we are teaching. So even the invite, when it come out with those infographics, so that when a healthcare worker see the ECHO invite via WhatsApp or email, they are able to see even those attractive comments. Even if the case was discussed some months back, it is so attractive for them to join in. Then ECHO is also part of our CPD, so it is connected. Number 3, we have an award system. At the end of the year, a healthcare worker who meets our requirement will be awarded. So everyone have the zeal to ensure that at the end of the day, I need to get awarded. A paper which will be signed by the permanent secretary, the director CDC, the country director CDC, the director JAPAIGO. Wow, this will add a plus on my CV. So we've curtailed the issue of burnout. So a healthcare worker have a choice to go for ECHO because it has got these advantages we've mentioned. And on top of that, the topics which we come out with, they are tailored to the reality. Then further to that, Bruce, we actually prepare. We have no crisis in case identification. So the clinical mentors, they are on the ground collecting cases, like a bank of cases. Every Friday, we have them discuss as experts and the facilitator, so that when we meet on Monday, we are offering what is really updated to our healthcare workers. So issues of connectivity, of course, remote area, we have some hiccups there, but we have a department under government which is in charge of the information system in the country. So we've actually launched our issue. They are working on it to see how remote areas can be assisted. And one thing about TB, community engagement is key. So we've noticed that we've not reached up to the community level. So we are working now, as we are talking, on the issue of community engagement and community ECHO. And also, what we do is that, like recently, we saw that we had a trend on a number of clients who are clinically diagnosed dying. So it gave us to say, no, we are having a gap. Maybe our clinicians are diagnosing TB when it is not TB. So it took us to ECHO to address that. So we had 2 weeks sessions, actually Monday, and Thursday, just talking about TB, how to diagnose TB on ECHO. And we are expecting to see change. I think those are the few we have.
Thank you, Emmanuel. We've got 5 minutes left, so we really hope we can address 1 or 2 questions from the audience. Anyone with a question? We've got two folks with microphones ready to come to you. If you raise your hand or stand up, we'd love to hear from you. Anyone with a question? Looks like someone.
Yep.
The lights are a little bright here. Okay.
All
Please,
right.
please.
Thank
say,
you very much.
Please say who you are and where you're from. And
Daniel Johnson, ECHO Chicago.
thanks, Daniel.
Thank for your presentations. They were very inspiring. And of course, the work that you're doing is awesome. I was wondering if you were to take the lessons learned from the TB program and then apply it to another disease state, what would be the critical take-homes in terms of structuring the next disease process to reach the kind of success you've achieved with tuberculosis?
Any of our panelists want to volunteer for that one? Ravindra?
Offer some tentative thoughts. You see, from the lessons learned from Indian experience, we can see that we had challenged ourselves to eliminate smallpox in 60s, then pulse polio in early 21st century, and then on we are talking about TB, and then we had a very robust response to COVID. But TB, even though we have been doing a program since 1960s, still continues to challenge us. So the lessons learned, most important lesson is that programs, though they are vertical from Government of India downwards, they have to be patient-centric and patient-specific. Otherwise, they lose their effect until the patient's concerns are addressed directly. And for that, the healthcare worker, the nurse, or the person who is called DOTS provider, unless they are supported in each and every manner. And Zoom is a great platform for that. For instance, they get demoralized sometimes by the work. The work is repetitive, not resulting in significant or substantial reduction. So their morale has to be kept up. And that can be kept up only in a manner when we have a sustained dialogue with them, or mechanisms to create that dialogue with the worker who is actually working in the field, number one. And number two, that community engagement which we have started, which is likely to be a very, very powerful tool, because we have found that earlier we were thinking that philanthropy exists only in West, and Indians don't contribute so much to philanthropy. But once the Nikshay Mitra came, we have almost 11 lakh people who have been adopted by somebody or the other for their TB treatment. So there is community sources have to be tapped.
Great. Thank you. And I wonder, Lan, I know the National TB program in Vietnam started with TB, but they also started chest surgery and a cancer program. How did you apply the lessons learned from the TB ECHO to start the cancer, lung cancer and surgery echoes?
Yeah, very quickly. I know we don't have much time, but I think with any ECHO program, starting from TB, the documentation of the evidence of its cost effectiveness and of how it works is extremely important. So not only across the board in the National Lung Hospital, but the National Lung Hospital leadership actually introduced the ECHO team to the National Children's Hospital, which has now become a super hub in Vietnam for ECHO, and which has been a catalyst in getting ECHO to sign the Memorandum of Understanding with the Ministry of Health of Vietnam just a few months ago to expand care and treatment for multiple non-communicable diseases in all of Vietnam. So I think just to document that evidence of the model of how it works, of how it saves financial resources is extremely important.
Thank you, Lan. And with that, we're at time. So I want to thank our panelists for sharing their experience. It's been really fabulous. It's been extraordinary to see the journey of the TB-ECHO programs around the world over the last 9 years, and looking forward to seeing more innovation, more creativity, and expansion to help eliminate TB globally. So thanks to you all. Thanks to our audience for joining us.